assistance. Everyone here has gone through more budget cycles than me, but it's a constant fight every year. My concern would be was if somebody's there for a lifetime, somebody's on there for 10 years. If they get better, fantastic. But if they're still addicted to something, if I'm saying that right, they still have an addiction problem. And with limited resources, even if it is $100 a week, whatever it comes down to, we don't know the numbers, but over the long span of that with limited resources, how do we as legislators decide, is this program effective? If somebody still has to be a product of an addiction and seeking treatment, which the taxpayers are essentially picking up, and it's been 20 years, at what point do we say there's a sick kid somewhere who's not receiving medical assistance because this program has been ongoing for 10 years or 20 years. It's nothing biased. I'm just curious at some point, when do you say we need something more effective, or we need them to take the next step, or we've got to help them?
Well, it would be nice if there was something less expensive that would be effective in the same way, but right now there's probably not. We have to believe, and I don't have the studies at my fingertips, but we have to believe that those dollars that are spent are cost effective in keeping people out of the illegal drug market, in keeping them at home with their family, their relationships solid, keeping them working. We have people working all kinds of jobs. About 20% of our people work, and they're working in insurance and banking. They're working in medical clinics. They're working some very responsible jobs. You'd be surprised, and that kind of benefit, is extremely valuable. So it can be an expensive service, but addiction is more expensive. That's all I can say.
Okay. Thank you.
Representative Barton.
Thank you. I want to follow up on a question that Senator Wozniak raised. I think what you told him was that the cost for the dosing is about $100 a week. At the same time, are there any other costs that medical assistance is paying? Are they paying for counseling as well?
Yes, that $100, the way we're funded right now through medical assistance, is a comprehensive fee. It's all inclusive, if you will, of the physician services, the nurses' services, the dosing, the medication, the counseling, the administrative secretary, myself. All administrative and clinical costs are covered through that fee. So there's no other, that I know of, there's no other fees.
Right. Then the other part of your testimony appears to be this idea that that when you do this methadone therapy, the all-inclusive therapy, that the brain actually changes, and it's now required of the person to have this counseling and dosage for an unlimited period of time, or some will need it for an unlimited period of time. What I have a problem with, and I don't understand, I don't think there's any statistics that show this, but how do you know that a person who would be given a more expensive therapy earlier but wasn't put on synthetic heroin wouldn't be able to operate in society without having the dosing? I mean, that's the part I think you're setting up a false choice. You're saying if we don't do methadone treatment forever for some people, it's going to cost us more money. But all we've really done is substituted a synthetic heroin for heroin. And we're basically treating them in an outpatient setting to keep them addicted.
Well, remember, they come to us with those brain changes already. They're addicted, and we substitute that medication of methadone for what they've been taking, heroin or pills. And
why is that better, though, than somebody who goes into detox and then spends a year or 13 months in a facility that gets them to change the behavior?
Well, that's great if they can do it, but remember, it's a
but
brain
we're paying for one and we're not
disorder.
paying for the other.
It's a brain disorder, and it's a craving they can't resist. You can't fight the craving for a narcotic because your brain needs it. Your brain is turned around and addicted to that medication.
Are you saying that people that have been on it for a year can't ever come off of it?
No, I'm not saying that.
Well, then it's not something that can be changed then. It sounds like it can be changed. Here's what our question is. We do have limited resources. And I'm not hearing from you anything that says why we should continue synthetic heroin for long periods of time versus other therapy sessions. There are places, Peniel's one in Cambria County, that actually takes you off of the drug, spends 13 months, and then basically has a success rate that's a lot higher than this one. This one says that 1 out of every 2 person fails. And they have one that says they've got one more than 60% of people not going back to crimes. So why should we be spending our money on methadone when therapy might actually get somebody free of the drug?
Well, that's great if it works. There are many paths to get into addiction. There are many paths to get out. We're one option. We're not the end all be all for.
But you're the one we're paying for.
Yes, right.
I don't have any further questions. Thank you.
Senator Wozniak.
I want one last question, since the next people up are one last question for enforcement. And this is, I guess a lot of people have this question too. Okay, I'll admit it. I've had a few pops of alcohol after hours, but I can't imagine going through the day under the influence of alcohol. When you're addicted, is it something that when you're on heroin, do you get high and then you stand down for 8 hours, or is it constantly that you have to be constantly under the influence of a drug 24/7? And I guess that's a question I have. When you're addicted to something, is it all the time? Not like a guy going out and having a couple of beers with his buddies in the evening, but is this something you do in the morning, in the afternoon, in the evening, Saturday, Sunday, Monday, Tuesday, Wednesday, even when you go to work?
It's a medic.
Not methadone. I'm talking about when you're addicted to the heroin, to the alcohol, to the opiates, and that's the question I have since you were the last ones here. Not the methadone issue. When you're actually being stoned. I guess I asked after you.
Okay. With the opiates, my prescriptions were not opiates. That's not the receptor sites in my brain that really flared up whenever I was into stimulants. As far as opiates, though, what happens is in the opiate, especially heroin, they have a half-life of about 4 hours. So when someone first uses opiates, they'll get an euphoria. They will feel high, they'll feel good, this is all right. Then when they stop that use, they come down a little bit lower. If you have like a line here, they come down below that line now. So they'll use initially to get high. But what happens is that line keeps going below. That pathway in the brain is starting to build more opiate receptor sites so that the tolerances increase, they have to use more. And whenever they're using now, they're not necessarily getting high anymore. They're using just to sustain themselves. So, and what happens there is, yes, they may get a a pure base of heroin that may get them high. And that's why you'll see some heroin users will chase after drugs if they heard somebody overdose on. It's very unbelievable for us, but they'll go after that because they know they'll probably get a better high off of it. But so now they're just sustaining it. They do have to sustain themselves every 4 hours or they're getting sick. Methadone has a 24-hour half-life, meaning it comes down after 24 hours. It changes kind of that metabolic process in the brain and the chemistry of the brain so that they're not chasing getting high anymore. They're stabilized and they can engage in treatment. So, and there's many pathways. There's other medicated assisted treatments out there also. Vivitrol, there's Suboxone, all that.
We'll wrap this up. I want to get back to that question. So 24/7, a heroin addict has to be under the influence of heroin all the time.
Typically they are,
That
they're
was my
using
question.
on a regular basis because of the half-life of the heroin.
Thank you.
Well, that leads to a couple of questions. If I understand correctly, and I'm not talking about the pros or cons, but methadone would enable a person, it's one dose a day. So that enables a person basically to function throughout the day.
Right, there is some clinics do split dosing, morning, afternoon, but we only do once a day dosing.
Mrs. Rosser, based on what you said, heroin has a half-life of about 4 hours. So, I mean, that's the difference. Basically, methadone would allow the person to function for 24 hours, where heroin, a high, would
They'd be chasing their high. They have to go out and be recruiting that drug on a regular basis. That's why you see the crime wave that you see. That's what you see in the communities, the destruction, and the costs that we see. What methadone does and what other substances that are used as medication-assisted treatment, what they do is stabilize it. This person now is not craving the drug. They're engaging in treatment. They have to come every day and do this and be engaged in treatment and start rebuilding their pathways in their brain so that when they do decide, and if they do decide to come off methadone, that they have enough support systems and enough skills built around them now. Whereas their skills were to go out and get their drug, now their skills are how do I stay clean and sober and being able to build that. That's the big difference here.
Okay, thank you. Dr. Broussard, do you know, does UPMC have a protocol among physicians with respect to the writing of prescription drugs, or especially for pain?
I'm not aware of one.
I believe that some of the health systems that we've talked to, or some of the doctors we've talked about, that's been mentioned about some type of a system-wide protocol for prescription drugs. Representative Marabito.
Real quick, I mean, based on what you said, the other part of the methadone treatment is that overdose is not an issue. Do you have folks ODing on methadone?
We observe very carefully for that. The dose that they get is increased gradually, so we can avoid overdoses.
But I mean, I guess what I'm saying is that the problems of getting street heroin where you don't know what you're getting, where it's more pure. But I guess here's a final question to you, because I know we have to move on. Is there a philosophical commitment to say we're going to get people off methadone? There was an implication that the person decides if they're going to get off.
To the individual.
But does that make sense? If someone is an addict, are they going to say, I want to get off something which is a chemical dependency?
We have quite a few patients who that's their goal, is to get off methadone. Either they're paying $100 a week, or they're having to come to the clinic frequently. They don't want to be an addict.
No, I know, and I hope that didn't imply that that's what I was thinking, but I guess what I'm wondering is if there is some finite point, but I don't want to belabor it.
Well, I'd invite you to go to a local methadone clinic and visit. I think most clinics would welcome having you in. We would. And go and tour and ask for that specific question at that clinic.
All right, thank you. Obviously, the topic of discussion was one of importance and of concern, so thank you very much. The final panel today is Kevin Price, a detective with the Cambria County Office of the District Attorney, and Gary Martin, the president of Cambria County Crime Watchers.